Good morning. My name is Al Liu, and on behalf of Lily, Kristen, and I, we would like to thank you for joining us for today's meeting. This is Symposia, Relationships Across the Lifespan in CF. Before we begin today's program, we would like to thank members of the CF Planning Committee, and in particular, our representatives, and they include Keisha Nelson, Christina Duncan, and Beth Smith for inviting us to co-facilitate today's symposia. And it certainly goes without saying that we wish that we were able to have this meeting in person and hope that that may be the case next year. We have no disclosures to make. We would also like to express our gratitude to our presenters who agreed to participate in the midst of all the changes we've had to make during the pandemic. And they include Tracy Kasmersky, Stephanie and Kevin Lynch, Megan Barker, Brittany Sines, Catherine Moffett, and Chelsea Urchin. Collectively, they represent clinicians, parents, sibling, spouse, and an adult with CF. Lily and I look forward to learning from each of our presenters, and we will have a live Q&A session after all the presentations. Thank you.
Hi, I'm Tracy Kasmersky. I am a pediatric pulmonologist and health services researcher at the University of Pittsburgh. And I'm excited today to talk at this symposium on the topic of improving CF care through relationship-centered communication. And I have a few things that I should disclose. First, from the CF Foundation, I do receive research grant support, and I am a partnership enhancement program consultant, and you'll hear much more about that later. And I also receive research support through the Children's Hospital Foundation here in Pittsburgh. So I wanted to start here with this incredibly simplistic graphic of a person with CF and their interaction with a healthcare provider in the healthcare system. And as you can see, this vastly underrepresents what a person with CF experiences in their relationships. Too simple. And I think that this is closer, also extremely simplistic. But as you can see, a person with CF really has a range of relationships that they experience outside the healthcare system that probably are more important than most of the relationships they experience within the healthcare system. And the other folks on this panel are going to talk about what those relationships look like from their viewpoints. But when we think about the healthcare system, it's not just a person with CF and their CF primary provider. It's the whole CF team. It's other specialists that they may see. It's primary care providers. And I think in thinking about the relationship between the person with CF and starting with their CF team, we know that over 85% of people with CF really view their CF provider as their main physician. In a recent study of women with CF, ages 25 years and older, among over 400 women that were surveyed, 41% did not even have a primary care provider. Recently, a study done at 5 CF centers here in the United States did some on-site observations at these CF centers, and then did interviews and focus groups with CF providers, people with CF, and families. And all these groups really agreed that they need better resources and training to connect with each other more effectively. And this was extremely important, specifically around ways to sustain their daily care or be adherent to therapies, as well as around transition from pediatric to adult care. But there's also relationships within the CF team as well. And we know that good teams do good work. And when you have good team function, studies have shown that you have better patient outcomes, you have higher staff satisfaction, and you've decreased provider burnout. On the other side, poor team function can lead to poor patient care due to increased adverse events, poor coordination of care across the team, and increased costs associated with care. Now, the CF team is unique, and this is a graphic drawn from the CF Foundation here in the US. And as you can see, there are many required team members on the multidisciplinary team, as well as recommended team members. And how the relationships exist within CF teams is really important to consider. And then there's the relationship between the CF team and other providers. In one of the interviews that I did several years ago with a young woman with CF, she articulated this: I have trouble going to other doctors that aren't my CF doctor, because I feel even when I'm at another doctor, it's all really CF related. And this idea that the CF team and CF care really trumps any other provider, and that trust is so inherent in that relationship, is really important. And it's not just how people with CF feel about going to other doctors, it's their experiences once they get there. So I think that the impact of specifically highly effective CFTR modulators and other advances in care and therapy in CF is really not often known by non-CF specialists. Many times, the last time someone has thought about CF or taking care of a person with CF is when they were still in medical training, which could have been many, many years ago. In one of our stakeholder groups, we had a person with CF share with me that she went to her obstetrician when she was around 40 years old, and he began the visit by questioning, well, you have CF, how are you still here? So making sure that we as the CF team are partnering and educating other providers about what modern CF care looks like, and what they should expect when they take care of people with CF is really, really important. So there are many relationships between a CF person with CF and their CF team, within the CF team, and then with the CF team and people with CF and other healthcare providers. So how do we improve these relationships? And I wanted to introduce you to the concept of relationship-centered care. And I think a really short way of explaining this is short and sweet by John Donne: no man is an island. But there are really 4 key tenets of what is relationship-centered care that I want to highlight here. So first, relationships in healthcare really ought to include the personhood of all the participants. So it's not just about what a person with CF or the patient is feeling, just like it's not all about what the provider's feeling. It's the relationship between the two. And I think as a part of any relationship, affect and emotion are really important components. The third one here really does highlight what John Donne said, is that all these relationships occur in the context of reciprocal influence. No man is an island. And then finally, the formation and maintenance of genuine relationships in healthcare is really morally valuable. So there have been several studies that have looked at the quality of relationship-centered care and connected it to health outcomes. And they've really found that high quality care and communication equals better health outcomes. And there's 2 that I want to highlight here because I think they're quite striking. The first was a study that looked at the benefit of a good relationship between a person and their healthcare provider and found it to have about the same effect as a daily aspirin to prevent a heart attack. And a second study looked at people with diabetes, and they found that people with diabetes whose providers had higher empathy scores, those patients had lower hemoglobin A1Cs and better diabetic control. These studies have been done in pain management, a lot around adherence. Really, the bottom line, if you're a provider or is a better communicator, you are experiencing better health outcomes. And then good relationship-centered care also leads to happier teams. So there have been studies that have linked better connection and communication with patients to higher physician satisfaction, higher engagement across teams, decreased work stress, and better communication leading to decreased malpractice suits. And I remember when I was in med school, we were told if you're a good communicator, you will get sued less. And that is borne out in the data. And I wanted to pause here and really highlight this idea that relationship-centered care and communication is a skill that can be taught. There is no such thing as, oh, I was just born being a good communicator. And the Academy of Communication in Healthcare, really over the past 40 years, has invested in the research and training around relationship-centered care and communication in this space. They have a lot of offerings around patient safety, around team building, patient satisfaction, and improving individual communication skills. And on the other side of the screen here, you can see a really good book that I recommend called Communication RX that talks about how healthcare can be transformed through these relationship-centered communication techniques. So after looking at that 5-center survey and interview study done in the US and CF centers, in 2018, the CF Foundation partnered with the Academy for Communication in Healthcare to customize the relationship-centered education for CF teams. And this is called the Partnership Enhancement Program. So what this really looked like is people from the Academy of Communication and Healthcare came and trained 4 CF physicians, 3 CF NPs, and 2 CF social workers to be facilitators of these relationship-centered communication techniques. After that kind of 5 full-day extensive training period, it's not advancing. There we go. Ooh, too much. After that training period, these facilitators went out and did workshops for participating and intact CF care teams that consisted of didactics and then small group skills practice. These were around 3 distinct skill sets. The first was around establishing trust and building a rapport with people with CF, negotiating an agenda for the visit, opening visits. The second being creating open dialogue. And really key to that is asking open-ended questions and responding to and addressing and recognizing emotion. And then finally, skill set 3 is setting goals by partnering. We did follow-up surveys and sessions to encourage the skills and see how things were going. In the midst of all this, we were hit by a pandemic. So this was transitioned from in-person workshops to virtual workshops. And accompanied by expansion of offerings, including skills champion practices, specific calls and discussions around how to use these skills in specific situations. If you're interested in the Partnership Enhancement Program, the best way to get in touch with them is to email pep@cff.org. I'll provide that right at the end of this presentation. But I also want to encourage you to tune into this on-demand session here at NACFC, which is applying partnership enhancement communication skills to navigate challenging care conversations, really to kind of get a flavor of what this is like and what these relationship-centered care techniques feel like. So I think that one thing to really be cognizant of whenever developing a new training or a new tool is it feasible and acceptable for the group that you're trying to educate? So that is what we did. And we asked if PEP was really feasible and acceptable. And as you can see, it already popped up. The short answer is yes. We looked at this through 20 workshops at 19 different centers with a total of 210 participants. And we really found high feasibility of participating in the PEP workshops for intact CF teams. It was easy to schedule, it was easy to participate and do. And almost all participants agreed that they could use partnership enhancement skills in their clinical practice and would recommend it. Now, does PEP and relationship-centered care improve CF outcomes? And you remember I had the slide that said that if you have good relationship-centered care and communication skills, if you have a provider that has that, it's the equivalent of an aspirin a day to prevent a heart attack. Do we know that for CF? And the short answer is we don't know yet. But I think it's really important that we think about future work that explores the impact of PEP and the impact of other communication skills work on how does it impact patient engagement and satisfaction with their care? How does it impact self-efficacy in having conversations with healthcare providers, both within the CF team and with other providers that aren't CF specialists? What is its impact on trust between people with CF and their providers? What about shared decision-making? And what about transition readiness in regards to moving from pediatric to adult-centered care? Adherence for sure. And then I think long-term CF health outcomes, AKA if you have a team that practices relationship-centered care and communication, does that translate into better lung function, better BMI, less pulmonary exacerbations for the patients and families they serve? So stay tuned. I think that work needs to be done and is really, really important. And I wanted to end with this idea, and I know that this audience knows this, but there's really been a shift. And, you know, when I was in training, I certainly thought about and learned about CF, and it looked like this in my mind. It was the lungs, GI system, diabetes, maybe some reproductive health, but it was the lungs. And I think that we've moved to this, where it's been equalized and things are gaining importance and shrinking in importance. And a lot of that is due to highly effective CFTR modulator therapies and their widespread use, at least here in the US, as well as other advancements and therapies and care. And that focus of CF care has really shifted. And I think that we can use relationship-centered care and communication to explore what this looks like, to explore the entire range of concerns for people with CF, and to really better understand how this has changed and how this is going to continue to change as we develop new therapies, extend the age for therapies that are already available, and what that looks like. Ooh. So I wanted to end there, and thank you so much for your time and attention. This is my email address, so feel free to reach out to me with any questions. And as promised, if you're interested more in the Partnership Enhancement Program, there's the email at cff.org to reach out. And again, I thank you so much for your time and attention, and I hope you enjoy the rest of the symposium.
Hi, and thank you for giving us the chance to speak with you today. I'm Kevin.
I'm Stephanie.
And we're from Portland, Oregon, and we are parents of a child with cystic fibrosis, now an adult, and we'd like to share our perspective with you from the experience we've had over the last 21 years. First of all, we want to note that the subject of the presentation is our son, Joe, who has given us permission to participate in this panel and to share all of the information and photos here. Joe was born in the year 2000. He was big for his age, but fairly quickly developed a series of conditions early on that were something of a mystery to us. He had significant respiratory issues, persistent ear infections, and what was clearly a number of problems with his GI system. He, of course, was very young and wasn't able to communicate with us, but we could tell that he had some things going on because he would show the manifestations of a sour stomach, and he needed a lot of comforting over time. He also had a very limited number of things that he felt that he liked to eat. We think about it in hindsight that it was probably that there were things that were more agreeable to him as he processed them. He also didn't sleep well. It took him a year to have one night where he slept through the night. And he was up often and just very, very uncomfortable frequently with a lot of bowel movements. When he was nearly 4, one day, he was really struggling. He was lethargic, seemed to be having a little bit of trouble breathing. And so Stephanie called the pediatrician's office. His regular doc was not on that day. In fact, I think she was on vacation. And he saw a different pediatrician, maybe for the first time in its nearly 4-year life, which was in hindsight a blessing, because a different set of eyes and a different point of view led him to be tested for a number of different things. Actually, the first thing that he was tested for was for CF, and this was back when CF was not something that was tested for at birth.
So after Joe had the sweat test, we waited the whole day for the results. It was a relief in some ways to know finally what was wrong with our adorable son. But it also was extremely scary. And I remember getting a call from the scheduler for the clinic, and his voice was so reassuring and just steadied me. And also, I remember getting a call from our pediatrician saying, you know what, he's going to do really well. Let's just get him up to the clinic, and let's do that. So we had our first clinic visit. And it went well. We had the two of us, we had Joe, we had my parents and my sister, and we were all in a room, and Joe introduced himself to the doctors because they were ignoring him. And anyway, and he stuck out his hand and said, "Hi, I'm Joe." Anyhow, the doctors were great. They assessed his immediate needs, which were for antibiotics and a lot of rest. And they put him on enzymes. We were introduced to the nurse, who was sort of our single point of contact. And they started to put together a plan for going forward, which was first to get him stable and get the lung infections cleared out and so forth. So it went well. But it didn't go as well as we'd hoped. There were some problems. We researched differences in outcomes among CF clinics. We found that the clinic we were taking Joe to didn't do as well as other clinics that were within driving distance. We don't remember there being a social worker or mental health coordinator on the care team. And this was just when the vest was coming out. And we thought, well, we should have him have a vest. And the doctors initially said no. And we only got one because of an intervention from a nurse. So we changed clinics and never looked back. So I guess the take home for this first part of our journey for the attendees is that we learned early on that parents are their child's most important advocate, and that you shouldn't be afraid to change doctors or clinics if it's necessary and if that option is available. We were very fortunate that it was. We also realized from almost the first visit to the new clinic how important the social worker was as a part of the team. And we learned that we shouldn't rush that part of the visit, even though there wasn't anything medical happening. And we're so glad that we didn't, because at a certain point, Joe really needed attention from the social worker. So the teenage years hit Joe pretty hard, the early teenage years. Some hard stuff happened. He had always been open about having cystic fibrosis, but it had never held him back. He was on the basketball team. He was in the school plays. He had friends, and he played the saxophone. And in any event, I don't know what happens in middle school, but some kids can get pretty mean. And a couple of them teased him about having cystic fibrosis and mimed like gasping for breath and things like that. In going into his freshman year, he developed Pseudomonas, which we had been so fortunate to avoid. He also somehow did his own research, I think, on the internet into cystic fibrosis and didn't tell us. What he found out was what he thought he found out was that he was going to die at a young age. He started to lose weight. He withdrew. And his lung function, while still normal, started to decline. This is where the whole clinic came through, and the value of having this great interdisciplinary team became so apparent to our family. His first clinic visit in 9th grade, I think, the doctor noticed something was wrong. I knew about the teasing, but I didn't know about the internet research. I prodded Joe to tell the doctor, and he told her what had been happening at school, and we all started to cry. Our social worker came in, and for the first time, he and Joe spoke alone, and he probed and found out about his internet research. And Joe gave him permission to tell us, which was so great that we found out, but we were devastated that he had been suffering for several months, really, and we didn't know why. We had started aggressively treating his Pseudomonas infection, and it took 2 rounds, but it's gone, and it's been gone ever since. He was 15 or 16. And then everyone else on the team was just great. They were gentle, they were kind, the nutritionist, the RN, the respiratory therapist. It was just wonderful.
Things started to get better for Joe after that period. But one thing probably worth noting, just to go back for a second on his research and his learning and the teasing, candidly, is that there was a section in one of his school science books about genetic disorders, and cystic fibrosis was used as an example for what it meant. It was an older textbook, seems to happen these days, and the outlook that was described in the educational material was very grim for people with CF. And that's something we never really knew, not surprisingly, didn't know about, and he didn't share with us. And so it's the kinds of things that are outside of your scope of knowledge and control that can make someone aware, and somebody particularly at a teenage who's so can be so vulnerable and sensitive. It's really important. So it's important to have that kind of communication with a child, whether it's with parents, social worker, doctor, all of the above, really, really makes a difference. But things started to get better with Joe. The Pseudomonas cleared up. Counseling that he was getting really, really helped him with his perspective and his attitude toward himself. And it was such a team effort among Joe and everyone in the clinic and his family, his mom and dad and his sister and his grandparents and aunts and uncles. It was a wonderful, wonderful thing. And Joe also got a used car right about the time one would when he was 16 or 17. And it gave him a lot of freedom, and it gave him a sense of responsibility and ownership, and something to look forward to. And things really turned for the better. He finished high school in a great place. The experiences that he had in school, in extracurriculars, he was in, I think, 7 of the 8 theatrical productions that high school put on over time. Got a girlfriend. He found lots of things to do and made some really, really good friends. And all the while, he was still, doing his therapies. He also, continued to see the medical professionals and the whole team at the clinic, and it really made a great difference for him. So again, back to what I just said at the outset here, you can't really control what your child might learn, but you do have to try to know what he or she does know, and manage expectations and attitudes and information around that, and to minimize the disinformation that may cause problems for a child. And clearly, the presence of a social worker and a physician and a team that treats the whole patient, that has a real holistic approach to care, is absolutely critical. So then Joe became an adult. He turned 18. Right around then, Orkambi was a little before he turned 18. Orkambi was approved, and then Trikafta, now about 2 years ago. He's now 21. He was accepted to college. He, very importantly, the social worker in the clinic got in touch with the university, which happened to be down the street, which maybe helped, but maybe not, and talked to the university housing department to make sure that Joe could get the kind of living arrangement that would with a cat. Okay, with that interruption from the cat done, Joe's social worker got in touch with university housing, who helped make arrangements for the kind of student housing that somebody with CF, an 18-year-old with CF, might need. He got a solo room with his own bathroom. It gave him space for his therapies, for his vest and his nebulizer, for inhaling saline, places to store his meds, and very importantly, a private bathroom, because when you're 18 years old and you have GI issues, that's a really, really important consideration to try to deal with. And living with complete strangers with that kind of condition might not make for an easy transition into university life. And I will.
So Joe started and thoroughly enjoyed college until the pandemic brought him home for 6 months. But he's back for his senior year, and he just goes to all the sporting events. That's him in the middle, cheering his little heart out at a game. We still go up every 3 months for clinic visits, and then our social worker gently told us before Joe turned 21 that it was time to leave. So, and it was time for Joe to go to the adult clinic. So we had Joe's final appointment this last summer. It was very, very special. His doctor, who had seen him the most, had retired. She came back. People came in, and it was just like another graduation. We were just so happy with the care he received, and so glad that he was healthy and could go on and was independent enough to take care of himself. So the things that we learned, we've talked about all the way through, but the take home as the child enters adulthood is that there's going to be transition periods. They're going to graduate from high school. They may or may not go into college, but they're probably going to go to an adult clinic. The social worker on the team can help, as ours did here. You can help in those transitions to college, to the adult clinic. The children's clinic provided just a crucial bridge to the adult care team that Joe's at. The mental health services, we can't overstate how important those are, and were for us. Young adults need assistance, and the social worker in our situation was able to help provide that bridge to the adult clinic and to ensuring that Joe has resources if he needs them for future care.
And I want to add one thing to that, which is, in hindsight, what we realized from the value of the social work aspect is that, as Stephanie said at the beginning, we weren't entirely understanding of how that service fit in to his treatment, but over time, and in hindsight, it became very obvious to us. So from the caregiver perspective, be patient with parents who don't maybe get it immediately, what your value is. And from the perspective of parents, build a relationship with your social worker who's part of the team. Hopefully there is one, the team that's assigned to your child, because you don't know when you may need that assistance, but it is absolutely crucial to have it. It can be crucial to have it. And it's not something where you can build a trust relationship overnight.
And with that, we will leave you with a couple of more recent pictures of Joe. He is a golfer, and he also is a cat lover. And we thank you for your time.
Thank you very much.
Hi, everyone. My name is Megan Barker, and I am going to be talking to you a little bit today about living with CF from a spouse's perspective. I have to disclose the following relationships. I will be talking about my husband and sharing his information, but he has given me permission to share his story with you guys. And I also have to tell you that I am the executive director of Project CF Spouse. So let's get started. This is me. Before meeting my husband, Ty, I knew a little bit about cystic fibrosis. As a respiratory therapist, it was something that I had learned about in school during the early part of my career. I had the opportunity to work with and take care of many CF patients. In caring for these patients, I spent a lot of time with them and got a glimpse into what living with a chronic illness must be like outside the hospital. After meeting my husband, however, I realized very quickly that I had barely scratched the surface on life with CF. My knowledge of cystic fibrosis was essentially textbook. I knew about the disease process and how it was managed. I knew that frequent hospitalizations were a part of life, but what I didn't understand was how much this illness really affected the lives of those that live with it and those that love them. We had been dating for about 3 months when he had his first hospital admission. Despite the fact that I met him in the hospital and knew that this was a routine part of life with CF, somehow the fact that this was my loved one who was sick was really scary to me, and it seemed everything that I knew to be normal about CF went out the window. I remember being afraid to leave the hospital and having this need to stay with him every day during those first few admissions. And it's kind of funny when I look back on this now. I'm surprised that our marriage survived, that we didn't kill each other in those teeny tiny hospital rooms, because you guys know there's not room in there, and you put two cranky adults, no good can come from that. But I'm grateful that he just went along with it and allowed me to stay. And I needed to know that that was okay, and that was just our new norm, and, that life would be fine. One of the hardest parts about becoming or getting involved with someone who had CF was trying to navigate learning about CF while having to teach people about CF. He got admitted kind of back to back, for the first, the first year we were together. And if I heard he's in the hospital again one time, I probably heard it 10,000 times the first couple of years we were together. It was so exhausting having to explain to my friends and family over and over again how CF worked, all while trying to keep my own fears and concerns in check. I distinctly remember being at Chick-fil-A hosting a fundraiser for our Great Strides Walk. This guy came up to me and we were talking about CF, and I was talking about Ty. And after I finished telling him our story, this man looked at me and said, "Well, what's your husband's life expectancy?" I remember thinking, please don't start crying. Please don't start crying. Please don't. It was such an unexpected question. I had just told this man all kinds of things about CF, but what he wanted to know was how long my husband was going to live. That was so overwhelming, because that wasn't a question that I thought about. I'm like, he's going to live forever. But the reality is mortality is something that we as spouses and we as people face. And I was very taken aback by it. And I didn't really know how to handle that question. When we got married, I made it a priority to attend clinic visits with him. There were so many things that I wanted to know, and I had so many questions. Granted, I had a decent understanding of medicine, equipment, and that kind of things, but CF was still kind of alien to me at this point. So I am very grateful to his team that they have always taken the time to listen to me. They've entertained my random questions, suggestions, off the wall emails, and crazy phone calls, and they have taken them in stride. They've never once acted like it was a bother or anything like that. And I am eternally grateful. I distinctly remember having a conversation very early on in our relationship with one of Ty's doctors, and she asked me what I thought and really kind of took my input into consideration. And that really struck me, because I remember thinking, wow, okay, I know nothing, you're the expert. But, she knew that I was a respiratory therapist, but above and beyond that, what she said to me was, you are with him every single day. What differences are you seeing? Are you seeing, is he coughing more? How's his sleep? Is it, and she was like, you're a very vital part of his care team as well. And I just, that has stayed with me. And it's just, it meant a lot, because, she's right. We do see our spouses and our loved ones, all the days that they're not in clinic. And so I do feel like we're kind of a vital tool, but it just solidified the love and respect that I have for his team. And they truly feel like family to me, so much so that it's kind of a running joke at our house that I talk to his care team more than he does. And pretty much anybody that's in this slide right here can attest to that. But they're just good people. And, they were my saving grace when it came to navigating life as a CF spouse. And I'm eternally grateful to them for everything that they have done for me and continue to do for Ty. From the beginning of our relationship, I was involved in the CF community. I participated in my first Great Strides event not real long after we started dating. And there I connected with some pretty amazing and supportive CF mamas. They were great resources for me to turn to, because they were able to answer the non-clinical questions that I had. But as anybody can attest to, a mama has a very different opinion than a wife. So talking to someone about treatment compliance from a mom's perspective is very different than that you're going to get from a spouse's perspective. So while these women were great, I was elated when I crossed paths with several CF spouses. It was such a relief to be able to say, oh my God, I hate an insurance company, or this hospitalization was a nightmare. Talk to me about this. And they just got it. There wasn't this whole need to explain things beforehand. It was just, hey, we can talk about this. And they understood. One of the biggest things for me that always has, I was very grateful for was I finally had a place where I could say all the things that I couldn't say anywhere else. I had a place where I could say, I'm scared. There was no judgment. There was no anything. I made a promise to myself when Ty and I first started dating that I would try my best to never add more to his plate to worry about than he already had. Now, life happens and things happen, but for the most part, I've held true to that. We have always talked very openly about his CF, and I've always tried to be mindful of what he's going on and not to add more. But, sometimes it happens. But I was so grateful to have these spouses to talk to because, I could turn to them instead of saying, oh my God, Ty, why are you breathing like that? Or, just whatever. It was somebody, it was a place to talk to where they got it. It was a safe place. And I saw something one time that said, find your tribe and love them hard. And that's what these people are. They are my tribe. They are my support system. They are where I go when things feel heavy. My relationship with them really made me recognize the importance of having other spouses or partners to connect with. As significant others, our experiences are very unique in our community and within the CF community. For many, there is very little, if any, knowledge of CF. What we know, we learn when we meet our partners. At the time that I started my journey as a CF spouse, there weren't really any resources specific to adult relationships at all in the CF community. It really bothered me that Google was the best option for us to turn to because let's face it, when you Google CF, it's ugly and it's overwhelming. And when you start applying those statistics to somebody that you love, it's scary. I remember the impact that my local chapter and Ty's care team had on me. And so I started encouraging all of the spouses that I met with to connect with their local chapters and their loved ones' care teams and really get involved because that was very pivotal for me in this journey. It still bugged me though that the resources weren't there for those adult relationships because especially with all the modulators that were on the brim at the time, there was a need. The CF community was getting older, there were more and more spouses. And so I just kept thinking, oh my gosh, there needs to be something. I'd had many conversations with other spouses over the years about their struggles with life with CF, how they coped. And it was always relieving to know that we were all seemingly in the same boat. The unfortunate part was that we didn't always know how to stay afloat. But little by little, one story at a time, something started to click. And it became apparent the valuable resource that we are to each other and to our loved ones' care teams. So in 2016, I applied for an impact grant from the CF Foundation and I founded Project CF Spouse. The stories and the experiences that I had lived, along with the ones that I had heard from these amazing spouses over the years, allowed me to kind of create a framework for this organization to provide that resource to the adult partner community that was missing, as well as the support that was so vital. I consider myself pretty well versed as a CF wife these days. That's not to say that there aren't times that CF throws us a curveball, but I've kind of learned to take it all in stride. And that's kind of my goal for any spouse that reaches out to me. I want to be able to share stories and experiences that have given us strength and guidance to provide the same path for new spouses and those that are just feeling lost. At the end of the day, I want there to be a beacon of light, a beacon of hope to light their path. Because I feel like sometimes it's so overwhelming. You need to know that good things are out there. I mentioned before the impact that Ty's care team had on my life with CF. Having them to help me navigate was such a relief for me. But not everyone in our spouse community has those established relationships. For some, it is as simple as a logistical or a scheduling situation where they simply can't attend a clinic or they can't attend an event or a function. But thankfully, in this crazy COVID world, telehealth has kind of allowed a little more opportunity for the spouses and the partners in the CF community to be able to attend clinic visits and join events that they probably couldn't have before. In other situations, though, and there's a whole plethora of reasons that this happens, the person with CF opts to exclude their partner from all aspects of their CF life. They don't want them to go to clinic. They're not interested in them being at the hospital when they're there. They just kind of have a wall up where, okay, this is my thing to deal with. I'm going to keep it separate from you. And that's great for them, but it doesn't change the situation for the partner who still has all kinds of questions. So in an effort to kind of help build those relationships between the spouses and the care teams and the local chapters, one of the things that Project CF Spouse has done is create a resource called Spouse Calls. These are monthly Zoom calls that allow spouses to virtually connect with not only other spouses, but also with care team members and local chapters from all over. It's great because it's an opportunity to have a real-time face-to-face conversation with someone, but you get to form those relationships. You get to meet care teams. You can, even if it's not your care team, it's a care team that you can ask a question. You get to learn about events that are happening within the CF community that it may or may not be something that your chapter does, but you can go back to them and say, hey, so have you guys ever thought about this? And then it grows and grows and grows, and it really builds the community. So I would like to take this opportunity to extend an invitation to anyone who hears this that might be interested in joining a call. So please reach out to me. I have included a slide at the end of this that has contact information for myself, as well as where to find Project CF Spouse. But we would love to, to share this with you guys and have you guys get to know us and us get to know you. You guys have been such a gracious audience, and I can't thank you enough for letting me share my story with you. It's my hope that after hearing me talk today, that you will remember me in Project CF Spouse. And the next time you meet a spouse or a partner or anybody in the CF community who is looking for a resource that they need somebody to talk to that knows what their life is like, that you now have a resource to send them and you can point them our direction. Thank you so much.
Hi, we're Kathy Moffat and Brittany Signs, and we're going to talk about our 23-year relationship as a caregiver and then to colleagues. Next slide. So we have no disclosures. Next slide. So I'm going to tell you a little bit about who I am, and then I'll let Brittany introduce herself. Next slide. So I've been at WVU for 23 years. I came and our center was not accredited. I became center director and we got our center accredited in the year 2000. I've been really lucky. I'm an infectious disease specialist, a little bit of an anomaly, not the usual specialty in CF care, but I've been grateful for many opportunities that CF has provided in my life and my career. And I have been doing CF for actually more than 30 years. Next slide. So just one slide on what we know about siblings of our patients with chronic disease, including cystic fibrosis. Well, we do know there was a recent study looking at siblings of CF patients, and they may experience some psychological difficulties. So this came from the aspect of a psychologist, the things to look for in siblings, whether they have anxiety, depression, troubles in adapting. Now, another article looked on the perspectives from the childhood to adult having a sibling with different chronic diseases, and actually found that there was resiliency and may help people cope in life and accepting their circumstances. So that's really what I found in the literature. There's really a paucity and it's room for improvement and maybe some studies. So my experience is that we sometimes, but don't always, see siblings, and I worry that siblings may feel left out. We give a lot of good stuff when kids come to clinic, a lot of gifts and stuff. And of course, they get a lot of attention, good and bad. And then do siblings understand what's happening during the hospitalizations or when there's disease progression? And I think lastly, do they understand genetic risks? Next slide.
Hi, my name's Brittany. I am a respiratory therapist with the Mountain State Cystic Fibrosis Center. I started working at WVU Medicine in 2010 after graduating from college at Allegheny College in Maryland. I was a critical care respiratory therapist for about 7 years and joined the CF team in November of 2017.
So Brittany, I've known you since 1998.
Yes.
And you were 3 years older than your sister, Tiffany. And tell us how you ended up in respiratory therapy.
So my original career path all through high school was architectural engineering. I took multiple years of drafting skills and things like that. My parents actually tried to convince me to go into healthcare, nursing in particular, and I wanted nothing to do with it. And then in 2007, whenever I lost my sister to CF, I switched my pathway to respiratory therapy. And I think the reason I chose respiratory therapy over nursing or any other discipline is because respiratory was the discipline that my sister most looked forward to coming into her hospital room. So I kind of wanted to have that same relationship with patients.
So next slide. So this is Tiffany, and I met Tiffany when she was 5, right? Would that be right, or 6?
Yep, 5.
And 5, and you were 8.
Mm-hmm.
And so you used to come to her visits with her most of the time.
Yes. So I a lot of the times whenever she would come to clinic visits, I would get excused from the day of school and come over with my mom and my sister. So I was very familiar with, what clinics looked like. I remember coming and watching her blow out the candles, which is kind of funny, so that's what I do in clinic now. But I remember seeing the clinic dynamic and, being very familiar with that from a very young age.
So one of the stories that I did not remember that you've told is one time when Tiffany came to clinic and you found something in her pockets.
So her clinic anxiety was always about weight gain. It was about PFTs too, but it was about weight gain. And specifically, one of the memories is sometime between our driveway and the hour drive to clinic and walking into the physician office center, she had picked up some rocks and put them in her pocket to try to show that she had gained weight. I don't remember who exactly found them, but when she was on the scale, they noticed a significant weight gain. And I think my mom was even like, that's not right. That can't be right. So they ended up finding her pockets were stuffed with rocks.
Yeah, I'm sure it was your mom. So go to the next slide.
Okay.
So this is Tiffany and Brittany's family, and you can see we're a lot younger there. I'm a lot younger there. But Brittany, maybe you can say, what years those are. Those are walks, and you have the team TIFF. So on the left is your cousin, and then your husband, and then your mom, me, and your mom and dad, right?
Yeah, and I believe that year was 2015.
Okay.
And then on the right is you and my mom, and I believe that was year 2012.
Yeah, that was quite a long time ago. You can tell by hair color and being younger. But I think that what it tells you is that we're a part of a family. I've been a part of your family for 23 years. And then when the job became available, well, even before the job became available, I know that I wrote you a letter when you went to college And then I wrote you a letter when you applied to become a respiratory therapist in our hospital. And then I would run into you and you would say, when are you going to have a CF dedicated respiratory therapist? And I kept saying, I'm working on it. I'm working on it. And then I think you were on maternity leave. Is that right? And I called you or messaged you and told you that we were going to be posting the job.
Yes, I was on maternity leave and coming back in a couple weeks to my, 3 12-hour day shifts. And it was kind of a decision I really had to think about because at that point I had, just a few-month-old baby. I had a schedule that I only worked 3 days a week. And then the more I thought about it, it was kind of like, why is this even an option? Like, this is the only reason you're a respiratory therapist. So then it was just like a no-brainer and I've never looked back.
But then I have to say that the job was very competitive and you didn't know that. And the rest of our team really didn't know you. I was the only one who really knew you. And we probably interviewed, 5 or 6 or 7. I know we had more applications, but we probably interviewed about 7 people. It was very competitive. But hands down, you were the one that we wanted. And it was clear to everyone on the team. And of course, I had a big vote, but it was a unanimous vote. So then that was the fall of right after NACFC in 2017, right?
Yeah, I attended NACFC in 2017 and then came back that Saturday and then officially started the position the following Monday.
That's right. You went to the meeting before you were even officially on our team, but you were on our team. Yeah. So go to the next slide.
Okay.
So Brittany and I talk about this all the time. What are the unmet needs for siblings? Because I don't usually see all siblings in clinic, like Brittany coming with Tiffany. And what do we do as CF centers for our families? So one thing is CF has really changed, and you can attest to that, right, Brittany, about how much CF has changed.
Yep, absolutely.
And you talk to families, not telling them that you had a sister with CF, but you talk to them about getting siblings involved, like in getting the vest set up or maybe neb cups or doing other things.
Yeah, so I do 99% of our newborn screen sweat tests. And a lot of the times families have had an older unaffected sibling. And then it's the younger or maybe even 3rd or 4th child that gets diagnosed with CF. And the parents, before they even get results are asking me questions during the newborn screen, because usually they're frantic and panicked. And they've asked me how do they take care of a kid with CF and also still give fair treatment to their older child or children. And I tell them almost hands down every time, let them be involved. Let them help set up their neb cups. Let them help put the vest on. Let them help pick what color vest they get. Help them, let them help do the sterilizing bags, things like that. Just to help let them feel like they're a part of the care so they know what's going on and things like that. I mean, I'm pretty sure I knew how to run a vest and a nebulizer probably at age 6. Because I would help my sister get her treatments ready and we would sit there and watch Gilmore Girls while she did her treatments and I would help her and things like that. So I think that was a big part of my understanding of why my sister got, I don't want to say more, but maybe like more attention toward her. I understood why, because I also was able to be a part of it. So that's my biggest thing that I tell parents is just let them be included.
Right. And not very many, a few of our families do know that you had a sister with CF. We actually do have, so one of our former patients who died years ago, now her brother has a baby and is a part of our center. So there's a connection that I think he knows because he knows you and you knew his sister. But most times our families do not know that you had a sister with CF.
Right. A few of our adult patients know. And And a lot of that reason is before I was in this role, I took care of a lot of the CF patients on the inpatient side. And when they're getting 4 or 5 times a day treatments and you're the respiratory therapist for them for a 12-hour shift, you're spending hours with them a day. And sometimes with the adult patients, it just kind of happens to come up because they're in conversation and ask if you have any siblings or whatever. And you don't want to lie to them. And when it's an adult patient, I don't feel as bad telling them because chances are they've already surpassed the age of where my sister passed away. So it doesn't make me feel as if I'm like giving them bad news or any sort of like, feeling of discouragement. But not a whole lot of our pediatric patients know. Some of them do because I go to the walk in my team TIFF shirt. And that's not many people have really asked me about it, but if they ask, then I say it. But I also always make sure to say, CF does not look like it used to. I mean, it's not the same thing. It's not the same thing as it was in 1993 or 1994. So I think that our outlook would have been totally different had we had Trikafta or Orkambi or Symdeko in 1995.
Right. And I think there is one patient who is a teenager who has lost her older brother relatively recently to CF. And I know that you talked to her about that.
Yeah, and that was kind of unsolicited too. So she kind of went on a hiatus from clinic there for a while. And then she had come back a couple times. And the one day that she was in clinic, she was just having a really hard time and was tearful with some of our other team members. And I just kind of took it upon myself to go in and talk to her. And she got very tearful and was saying that she was the loss of her brother was hitting her really hard and she was scared. And I kind of just felt like it was the right thing to do by telling her my history and telling her, like, I don't know what you're going through as far as having CF and seeing that happen, but I do know what you're going through as far as losing a sibling to CF. So, I think I spent 15 or 20 minutes with her just talking. Her mom stepped out of the room and just kind of let me talk. And I think she didn't really say a whole lot, but she definitely heard me. And she, I think, appreciated that ever since, because I've seen her a few times since then, and she just seems to be much more open with me. And she'll tell me, she'll be completely honest with me as to what she's doing, what she's not doing, and things like that.
I think that's really nice. The other thing that I think is helpful you are for our team is that we look at you and say, well, what does a family feel about this? Are we going overboard, or what do you think? And that's very helpful. Sometimes I feel bad because I think that we vent a lot about as caregivers of CF, but you never take offense at that, and you help us to put it in perspective of understanding that it's hard for all of us in caring for a chronic disease. So that's appreciated. Can you go to the next?
I try. Yes.
Yeah, I know. I think that the dynamic that we have with our team is really wonderful. And it's about relationships, and it's about being a part of families, and the Morgan Science family is certainly a part of my family, and these beautiful pictures of Tiffany. And we had a picture earlier of your daughter. So your daughter looks a lot like Tiffany and your mother.
And is named after her. So that's also special.
Yeah, that's very special. Well, thank you very much.
I think it's also important to say that the day that this is going live for NACFC is actually my sister's birthday. So I kind of feel like this was a little bit meant to be.
That's really special. Yeah. So thank you for letting us share our story with you.
Good afternoon, everyone. Hope that you're enjoying the conference so far and enjoying our symposium. My name's Chelsea Werchin, and I am presenting the patient perspective on relationships across the lifespan. I am a CF survivor, a lung transplant recipient, and a clinical psychologist based in Dallas, Texas. I don't have any relationships to disclose related to this presentation. And I wanted to start out by giving you a little bit of my history and background. So I was diagnosed with CF at the age of 2 months, which back in the 1980s was essentially considered a death sentence almost. The doctor dismissed my mother, told her to take me home and love me while she could. I survived, and then unfortunately at the age of 11, I cultured cepacia, which again at that time was considered a death sentence as well. The doctor sent me on a Make-A-Wish trip. But then with the advent of new medications and new knowledge about these bacteria, I was granted a second chance at life again. And with that chance, I ended up graduating high school. I graduated with my bachelor's degree and with my master's degree. Then I started my doctoral program in psychology. During the middle of that program, I had a bilateral lung transplant in 2017. I survived and graduated with my doctorate and am now a clinical health psychologist. And that's owing to the many experiences that I had growing up with the medical system and with living with a chronic illness. Those things have pushed me forward into this field. So as you can tell, life so far has been a pretty big roller coaster, and I can't wait to see what's next. I can't believe I've made it this far and know that the relationships I've had with my family and friends and my healthcare teams have made this possible. Now, while I could spend the next few minutes waxing poetry about my insanely supportive relationships with my friends and family who have come through for me time and again, I feel that this forum deserves focus on my healthcare team. Throughout my journey, healthcare providers, including physicians, nurses, PAs, respiratory therapists, PCAs, physical therapists, pharmacists, they've all been my physical lifeline, but also a source of social support. At times, this arrangement has worked wonderfully, and at other times, it's been a miserable failure. So we're going to talk about that. Now, from a psychological perspective, the doctor-patient relationship often represents what we would maybe consider a crossroads. You know, crosses multiple domains and different roles. And this creates a very unique dynamic between the patient and provider. In many instances, the doctor has been viewed as the expert, right? Somebody who the patient who doesn't know much about medicine should just listen to their doctor and do exactly what they say. And as I'm sure you are all aware, that doesn't work so well with chronic illnesses, particularly CF. As patients, we grow up being in the hospitals, taking medications, doing respiratory treatments, receiving countless procedures. For myself, I'm pretty sure I was swallowing pills and could spell pharmacy by the age of 3. So we tend to have much more knowledge of our disease process and physical health than your average healthy person. Thus, the age-old doctor as the expert dynamic doesn't really work out well in this situation. While the doctors and all of the healthcare workers are the experts at the medicine, patients, we are the experts of our own bodies. So when a doctor doesn't allow me to participate in a conversation about my care, my reaction is to become frustrated and angry. For some patients, this is also can include problematic adherence, which we definitely don't want. The best relationships that I have experienced with my providers has been based on this idea that we both have important information and roles to play in my healthcare. Collaboration is necessary. Now, relationships with medical providers is not only about the medication and the treatment of the disease, right? It's about the connection and communication and support of the patient. Healthcare workers provide support to patients on both an individual level and a systemic level. At the individual level, most patients need that compassion and empathy from their doctors and healthcare providers. Please just be willing to sit with us in our discomfort. Listen to our concerns. My personal experiences with this topic have basically covered the entire spectrum. I've experienced doctors who just simply opened my hospital room door, stuck their head in, gave me some bad news, didn't even set foot inside the room. I was left an emotional wreck without somebody to run my questions and concerns by. Essentially a bunch of pieces that my family had to come and pick up and put back together. On the other hand, I've experienced amazing individual support, such as my physical therapist, who after my transplant was, I can remember her kneeling down in front of me and looking me in the eyes. So I could see her, right? I could see her eyes. And she went that extra mile just to help me feel comfortable in order to get up and take my first steps. I've had countless nurses who have sat with me as I cried or went the extra mile to help me feel comfortable. Even on occasion, opening my pill containers in front of me so that I can see exactly what medications I'm getting and what they look like. Now, one very special relationship that I experienced as a pediatric patient was with one of my hospital nurses. His name was Charles. You can see him pictured with me here in the lower left corner. Now, not only was he a great nurse who deeply cared about his patients, he was also a clown and a jokester. I mean, just what a child needs when they're in the hospital, right? He was young at heart. He regularly dyed his partially bald head, crazy neon colors like orange and green. And then him and I, we would have syringe fights. Essentially, he would sneak into my room and squirt me with a 10 cc syringe full of water. So of course, I had to retaliate, and I would get one of those huge 60 cc syringes from like maybe the RT, and that's what I would squirt him with. He was usually the one going home soaked at the end of his shift. But he provided the experiences that made my hospitalizations tolerable and even fun at times. So of course, I and my family grew very close to him. He became a part of our family. As you can see, he was present at my undergraduate college graduation. He is the one who convinced me to ride Scream at Six Flags for the first time. He even dog sat for me a time or two. Now, unfortunately, he passed away a few years ago. And of course, that was a really hard time for me and my family. But I feel so lucky to have had that relationship with him and have him as a huge part of my memories as a child coping with this disease. I also remember my doctors encouraging me to continue pursuing my life goals and passions, despite having experienced a major acute rejection episode just a few months before my internship interviews. What I would also recommend is that healthcare workers encourage patients to engage in mental health care services. Now, I do say this as both a patient and a psychologist. There are evidence-based therapies that I have seen work and help people struggling with chronic illness. I personally am a huge believer that CF clinics need psychologists on their team. Now, while we have social workers, unfortunately, they're often overwhelmed trying to tend to patients' emotional needs and provide resources regarding benefits and insurance. They simply do not have the time to provide the psychological care that is often needed. There is also the relationship between the patient and the healthcare system, right? So this can include the CF clinic, other specialty clinics, the pharmacy, the hospital. Now, my relationships with the healthcare system have always depended on the communication and coordination that occurs within that system. Many of my experiences with the system as a whole have basically focused on transitions. For instance, transition from pediatrics to adult care, transitions between different CF clinics, being referred to specialty clinics, and finally being referred to my transplant team. My first major healthcare transition was from pediatrics to adult care. Unfortunately, this experience went horribly. As you probably know, transition from the protected cocoon of pediatric care to the intricacies of adult care is a really difficult change for patients. As children and adolescents, we often grow to trust and feel safe and secure with our pediatric team. The idea of our entire healthcare network changing is scary. It's frightening. For me, there was a very limited period of transition, and my pediatric clinic and new adult clinic didn't communicate with each other. My new adult clinic did not stay in touch with me regularly or even schedule follow-up visits unless I reached out. I finally had to go out on my own to seek out a different adult clinic that I felt comfortable with. And looking back, I realized that I had to develop my own voice with regards to my health. I had to be willing to take responsibility and speak up because no one else was going to. Now, if we view the CF team and clinics as a source of support for patients, this transition process should have gone more smoothly and had more communication, better communication between those clinics. This idea also applies to changing CF clinics, which when I've had to do that in the past, I've always felt on my own navigating that process. On the other hand, I felt that the referral and transition to my transplant team went wonderfully. I was referred early in order to get to know the transplant team, and it was a gradual process leading up to the transplant. I felt that my two clinics communicated with each other and felt supported by both of them during this very scary and overwhelming process. My transplant coordinator has been one of my most valuable assets during this process and a source of support throughout my transplant. Here was someone that was very clearly appointed as my contact for when I had any questions or concerns. And she's always given me encouragement and validation for the many hurdles that I've had to overcome and for the achievements that I've achieved. Now, at a systemic level, transitions and referrals between clinics need to be improved. Some clinics and systems have great protocols in place, don't get me wrong. However, others need to make revisions. Focus on providing patients with support that fosters their independence so that we can feel confident in pursuing our goals while also keeping ourselves healthy. Continue to gradually introduce the idea of transition or even lung transplant to patients early on so that we have time to learn and process the information on both a logistical level and an emotional level. So to sum it all up, my point is this: your interactions, your relationships as healthcare providers with patients and families are important. You need your support. And I just personally want to say thank you for everything that you already do to give us that support. Some of my recommendations, improving policies at the systemic level for improving communication between clinics and having smoother transitions of care. And at an individual level, help us feel heard and understood take our thoughts and feelings into consideration. Let us be a part of those conversations. Again, we can't fight this disease without your continued support. Thank you.
Hello, everyone. I'm Lily Kristen. I'm a clinical psychologist and the mental health coordinator for MUSC's pediatric and adult CF teams here in Charleston, South Carolina. The power of having so many of us gather together this week virtually during this ongoing pandemic truly highlights how precious our professional CF relationships and learning are. Thank you so much for taking the time to join this session today. I also want to give my wholehearted thanks to my co-chair for the symposium, Al Liu, who's unable to be here today live and has been totally instrumental in putting together this symposium. And a special thank you to Paula Lomas for joining us today and volunteering with your kind help with co-moderation today. I also want to share a huge thanks to our presenters. We've learned from them and they've given a voice to the importance of social contacts and interpersonal relationships and relationship-centered care for people with CF. They've inspired us today with their personal experiences, strategies, suggested areas to focus on to enhance the relationships and support for our patients across the lifespan, and have shared a lot of valuable resources available to the CF community. We've also learned that focusing on and acknowledging our patients' relationships makes such a critical difference in team-based CF care. And without this focus, we really do miss much of what happens in our patients' worlds outside of the clinic or hospital settings. Very importantly, we also know that the social support makes an incredible difference to managing stress and increasing resilience as our patients navigate living with CF, both for them and their families. So thank you. I'd like to reintroduce our presenters briefly as we enter into the Q&A session. First, we have Dr. Tracy Kasmersky. She's a pediatric pulmonologist and health services researcher from the Children's Hospital of Pittsburgh. And her current research is focused on improving the comprehensive care for adolescents and adults with CF. Kevin and Stephanie Lynch are parents of a wonderful son who was diagnosed with CF a few weeks prior to his 4th birthday, and he's now an adult and living his best life as a senior in college. Megan Barker is married to a person with CF and is also a respiratory therapist. She also started the organization Project CF Spouse, which she spoke about today. Brittany Signs is a respiratory therapist whose career was inspired by her sister Tiffany, who had CF. And Dr. Kathy Moffett is CF Center Director and a pediatric infectious disease specialist. And they're both from West Virginia University in Morgantown, West Virginia. Dr. Chelsea Werchin is a patient with CF and a bilateral lung transplant recipient. She recently completed her doctorate degree in clinical psychology, a huge accomplishment, and will soon start working with a healthcare team in Dallas, Texas. And her research is focused on the psychophysiology of respiratory disease, and she continues to really work on seeking out opportunities for improving mental health care of patients with CF and disseminating knowledge of this disease. We're so looking forward to having some question and answers today for our presenters. And just as a reminder, if you could, please put any questions in the Slido box versus the chat box, that would help us out greatly. I'd love to start out with one of the questions that has kind of moved to the top here. And this is a theme that we've heard throughout our presenters today. So I will start with a question for you all. What suggestions do either parents or really all of y'all have for social workers and other CF team members in clinics that may help with transition to adult clinics, how to make it smooth, empowering, and not traumatic, importantly?
Lily, we'd be happy to start with that as parents.
That'd be wonderful.
Okay, sure. I would emphasize the word transition. It's when you go from being in pediatric to adult care, it's not just a flip of the switch. You can see it coming, but creating a ramp, getting the patient and the parents familiar with where someone might go, where the patient might go next, with the environment that the patient will be moving into. Adult clinics are different from pediatric clinics, I think, in at least sort of in style and culture as far as we've observed. So just taking a little bit of time to get everyone acquainted with what's coming next is the best way to do it. I mean, we started thinking about it with Joe when he was 19 or so, and he took the full period of time he could in order to transition out of pediatric and into adult. But it took him getting comfortable with that change. So I think time is the most important thing to stress.
Yeah, and I think Chelsea may, as a person living with CF, have had this experience. But just in hindsight, and by the way, I didn't see it coming. I thought we got to stay with Joe's clinic forever, and I got to go to all. Anyway, the nice thing that I think having the social worker involved early on was that he helped us help Joe become independent. So it wasn't as big of a transition because Joe knew how to take care of himself by the time he got to the adult clinic. And in fact, we weren't able to go to the first appointment because of the pandemic, and he did just fine.
I think what the Lynches have to say is absolutely true. And their video, they talk about when their son Joe was 12 and had read the stuff and was anxious. And there's the beginning, or it even starts before then, the beginning of the transition process. The end is the transfer, the handoff, but it's getting the steps in place. So I think you did that with your son, and the team did that in helping him to be seen by himself, understand what his meds are. When those fears come up, the communication, and getting ready to go through the steps of the emotional and the physical, all the readiness, so that when the time comes to make that transfer, you're ready. But it has to start early. I think it starts way even before 12. Getting kids to know what their meds are, what they have, why they take what they have. It's a process, and it's a ramp, like you said, Kevin, but it starts really earlier, and getting the parent ready. Because if you haven't been talking about the fact that your kid could go to adult clinic and you might not be allowed to be there, well, normally you would be, but with the pandemic, there's the process.
Yeah, I definitely agree with Dr. Moffitt on that, that this is just a very lengthy process of transition, right? And like you were saying, there's a whole bunch of pieces that have to fall into place along the way, from having patients know exactly what they're taking, how to manage their own healthcare routine, and even getting to that point where patients are doing things like making their own appointments, talking on the phone with insurance companies, that, ordering their medications. These are all like little things that as you're developing and as you're growing up into adulthood, that they can be big hurdles to sort of overcome in that transition period. And then, I think kind of piggybacking off of what I was talking about in my presentation is that communication between the two clinics. I think making sure that there is an overlap, right? That it's not just, okay, here's your last day in peds, we'll see you later. Your next appointment's going to be with adults and we'll never see you again. Mm-hmm. I think that it's helpful to have sort of an overlap where maybe the patient at one point goes over to the new clinic and introduces, meets the new doctors or the new social worker, things like that. Sort of starts to get to know that care team, and they get to know that patient. So they feel a little bit more comfortable easing into that.
And I think also from a spouse's perspective is that we come into this usually after that transition has been made, but most of us come into it not knowing anything about what living with CF has been like for all this time. So I think recognizing that you have a different dynamic too that's coming in would be beneficial.
And I think the other thing that I'd comment on transition and getting a person with CF ready to take more ownership of their own care and rely less on their family members, is really our ability on the pediatric side of things to encourage self-visits of people with CF with the entire multidisciplinary team. So we try to do that very routinely and intentionally. And I frame it to the teen, as well as to the family members present, that my job is to prepare you to be able to take care of yourself. So you're going to do this one yourself today, and we'll bring your parents in at the end. And I think the anticipation is always much more scary than the actual process of doing a self visit. But by the time they're, off to the next step after high school, it really should be, oh yeah, my mom is going to come in today, versus, the parents really driving those conversations. So I think that's my plug for self visits. And I think both people with CF and parents can encourage that as well, to say, actually, you go in by yourself today, and I'll come in later, if the team isn't being proactive about it. So I think from both sides, it's really important.
Thank you guys so much for sharing that. I have in our chat here too that there's some suggestions about actually having the adult team come in and meet the pediatric patient in clinic and kind of come into where the patient is, if that's conceivably possible. I know that that's not always possible for separate centers, but that was something that was brought up, as well as the CF Rise program. So just to direct your attention to the chat for that link. We had a kind of a related question, which I'll throw out to you guys all now. So in the instance of when things don't go as well with transition, or if you're on the adult side, do you have any recommendations for post-transition to an adult center that might be helpful? So things that you might recommend if you didn't get necessarily all the information in during the transition, or how to kind of address transition on an ongoing basis for our young adults getting to the adult side?
I would say, because I didn't have a great transition experience. So I think what it took for me was taking some responsibility for myself, and being willing to go out and search for another clinic that I would feel comfortable with. And that was really scary, because it was like, I'd been with my pediatric clinic this whole time. And so this concept of you can go to another clinic, it's okay, that was very foreign to me. And so I think also maybe this can be incorporated on the pediatric side, or even on the side of like the family and the caregivers, that, it's okay to step in and say, hey, like, do we need to look at something different? Is this something that's not, or is this something that maybe if we just have some conversations with the team, are there things that can be fixed to help this sort of go a little bit smoother from here on, or do we need to look elsewhere?
I think this too comes back to some of those kind of relationship-centered care and communication principles. Anytime, I think that on the pediatric side, we often have the luxury of, and the joy really, of watching our patients grow and become young adults. And that rapport is built with patients and families for decades. Whereas on the adult side of things, often, you really have to start from not knowing someone and building that rapport. And I think that trust isn't something that is immediately gained, nor should it be. So that ability to have a dialogue, not a monologue, as a provider, and really have that rapport develop and that trust develop is really, really important. So I think that for providers on the adult side and for people transitioning over to the adult side, I think it's just really about focusing back to the basics on who, getting to know who each other is, what the process is for that clinic, and what the similarities are, the differences, and then how do you best partner together going forward.
There's a question in the chat about what about a family who doesn't have the option to go to a different center? And I think that's a challenge. What we found is we have many more providers now. I'm not the only one. In the beginning, I kind of was. I don't take offense if someone chooses, you have your choice of who your primary is going to be. Maybe you have a hospitalization, or maybe the time when you need to come to clinic is different when I'm available. Different reasons people meet the other providers. And I'm not a pulmonologist. And so for some people, they want to see pulmonary. So we make that change. And we have to, as providers and as a team, embrace that, to say that that's okay. What we've also done is paired up people to go in so our visits aren't so long. And we've empowered some of the other members of our team to have a conversation about certain things that may not be with me or with the provider, which I think then allows maybe working on a relationship in a different way. We have some families where we just do not bring up the growth curve. We don't talk about what their BMI is or what their weight is. And we know that's the elephant in the room, because that's created a lot of stress. And I think that's helped to foster relationship. But I think it is challenging when, the Lynches said they changed care center, and then Chelsea says she did. And one thing that I always tell families is you need to always be in an accredited care center, and how you find them and where they are, cff.org, and look for that. But to say, I'm not going to be offended if you go somewhere else. We have a big care center down the road. You go there, go talk to them, find out if that's a fit. Well, actually, that's where you are, Tracy. It's okay. But I think letting people know that, you sometimes have to say those things. You have to be a little more concrete, or why aren't things going well? Maybe you just have to say, I sense that things aren't going well. What can we do to help to make it better? Am I not listening? What am I not listening to? I think those are really challenging things. And that's all what Tracy was talking about, all about the relationship and the communication.
Well, so we had some backup plans, because I wasn't even sure back then that we were allowed to go to a different center. That was not something that our center offered up. I won't get into it. But anyway, so there were a couple things that we did that helped. One was we enlisted our pediatrician in helping us get Joe seen when there didn't seem to be an urgency to see him, and we thought he should be seen. And that helped. The other thing is, and I agree with you, Dr. Moffitt, you should be in an accredited center. But one thing we did when we did change clinics is we wanted to have a backup down here, and the clinic wasn't willing to be a backup to our chosen clinic. So we found a pulmonologist at another hospital who had been a military doctor who treated patients with CF. And so we had Joe establish a relationship with him just in case something happened on an emergency basis where he would have needed to be hospitalized. So anyway, but I think our pediatrician was a great ally, and had some deep ties in the medical community, and I think maybe did some behind the scenes work on our behalf.
I'll just add, as Dr. Moffitt said, there are usually multiple doctors within a center, and if you don't like a doctor you're assigned, try another one. And I think we had better communication with the first clinic that Joe was at, with some doctors and with others. Similarly, other people as part of the care team can be better channeled. You just communicate better with some people than with others, and that's really important. The bottom line to all of that is that you have to be active. You can't take medical care passively as a patient or as a support parents or family members of the patient. So, take initiative, plan what you want to try to accomplish at a clinic visit, and don't just let it happen. Those things really need to happen. You need to do that if you don't have a lot of options.
And just one final thing, might be more of a nuclear option, I don't know. But I think each hospital has a patient advocacy group. I think each hospital has a patient advocacy group or an ombudsman, and maybe you could go to that office. It might even be confidential, and that might help too. But we never wanted to be seen as complainers. We just picked up and left. But we realized we were so fortunate to be able to do that. And if we hadn't been, that may have been an avenue that we would have availed ourselves of.
Thank you guys so much for sharing all of those perspectives. And I want to draw everyone who's watching your attention to the chat too, because there's some great suggestions about how to work on transition from the team perspective, including having regular meetings, having a QI group that's dedicated to that effort, just so you're aware. Before we move on to the next question, any other perspectives on that one to share?
Specifically
Go ahead.
to transition, I'll just say the on-demand session that I kind of plugged in my talk on partnership enhancement, there's a really wonderful 15-20-minute presentation by Brandy Midauer-Oxler from Emory, specifically using those skills in relationship to transition. So I would encourage everybody, she's phenomenal and an expert on this, just to watch that and see kind of the tips and tricks and ways she applies that to the broader picture of transition planning for CF teams. But I think it's really worth the time for sure.
And I will say that every clinic needs to have a Brandy in their team.
Yes.
She's wonderful.
Yes, Brandy's phenomenal.
Thank you guys all so much for sharing. Kind of on a related note, I think one of the things that you all have highlighted so clearly is one, that the relationship is important, but also really getting to know the patient themselves is really important in transition. So one of our questions from the chat is, any advice for a care team that has a parent who really just does not want or refuses to let the child be seen alone? Anybody have any suggestions or tips for them?
So this is super rare, I will say, but it definitely happens. And I think that when things like this happen, I will explore the reason why it is the case from the perspective of the parent, like what's driving that reticence. And then I think if it is, not something that's modifiable, really being very clear in explaining why self-visits are very important. And I frame this, I think self-visits are important for lots of reasons. One is confidential sharing of concerns, including around reproductive health. And I think that that's crucial for adolescent health. But I think that I will often frame this in the transition of care framework to say, I need them to be able to answer questions by themselves. What if they're away at college? The reasons why it's so crucial from our perspective. And if it's still kind of a something that's just not going to happen, I think that my encouragement of the parent who remains in the room is that they will try to be as reserved as possible and not be the first one to answer the questions. And I will speak directly to the teen with CF and anticipate that the dialogue will happen between us with very limited interjection from the parent. And I'll just try to kind of keep encouraging that. But I think I also recognize that this usually comes from a place of deep caring. So it is, if the parent didn't care, they just wouldn't care. They would, not kind of be as involved in this. And I think that I recognize that this comes from a place of deep care and real advocacy. So I recognize it, but I also recognize it's really important. And I do try to keep pushing. Kathy, I don't know if you have experience or thoughts on this as well.
Yeah, I think it's challenging, and we haven't done so well. We recognize as a team, we started a QI project in 2019, and then the pandemic happened. And what we found is that if someone wasn't in the room, they were told they had to go to their car. So in peds, we allowed visitors. Adult world, they didn't even allow anyone to come in the clinic with you, but at least for peds. But then we couldn't. So we're kind of back to square one again now, which is trying to figure out how to do that. So it's a challenge. It is a challenge. But I like the fact that you say it in the way that it comes from caring. Because I was sitting here thinking of a few teens who came without a parent and had no parent involvement in the last years of their pediatric life. And that was very sad. And so actually, when you have a parent there, it tells you that they really deeply care. But I also worry about that parent because I think we said, as Stephanie and Kevin said, it's getting them prepared to let go. So it really is helping there's a nice illustration in CF Rise where the patient responsibility goes up and the parent responsibility, is simultaneously going down. And we have to remember that we're really helping both of those, that dyad, because to be successful, you got to get there.
I want to add to, from Tracy, you hit on this when you said that about HIPAA. It made me think about it. So the struggle that I have, my husband's 43 years old. I have without him saying, Megan, it's okay for you to know this. I have no say in any kind of conversation with any of his providers. And so I know that you have people who have questions and may reach out to you. And I would just encourage all of the adult clinics to really take the time to figure out ways to have those conversations with the spouses and the partners who reach out to you. I mean, obviously you have to protect the privacy of the patient, but just because our loved ones don't want to talk to us doesn't mean that our questions go away. And, again, I go back to saying, don't let Google be the resource, because, it creates more anxiety around this. And I feel like this is a struggle that the adult community has that the pediatric one doesn't, because as parents, we're allowed to know things about our kids up to a certain point, and then that kind of goes away. And so I would kind of encourage you guys to, when you think about the dynamic that you're serving, to just recognize that one little part of that, we're not privy to all the information, but we have a ton of questions.
I think, just to put in my perspective, I've been described as not just a helicopter mom, but a snowplow mom. And so we didn't, our pediatric clinic didn't have the program that you've spoke of, but it probably may have been a good idea, but I would have needed some time. And maybe one thing to do would have been to gradually introduce it. Like the first time, it would be just that the patient just met alone with, I don't know, the nutritionist or the social worker, which our son did anyway, and then lead up to it, like make it gradual, because snowplow moms, that would have been hard, but I understand now the need for it.
I observed over time how the caregivers for Joe would increasingly address him and less us.
Yeah.
And that's a very, very, very important tactic to take for both parents and for the patient.
Yeah.
So I want to transition to another question. We have so many great ones that have come in. Thank you all. Someone had commented that, we really agree making time for a social worker or psychologist in the CF clinic is vital, but we already have very long clinic visits. Do you all have any suggestions about, making sure that each team member's time and role is honored in those visits? Because we all want to make sure that they're getting the best specialty care from each discipline.
So at our clinic, I think they had a little thing on the door about who was in. So I think our clinic may have figured out how to honor that so that nobody was interrupting anybody. I don't know. That's more practical, I guess, but it seemed like it was.
That's a great suggestion.
Yeah, I think from the clinic perspective, from what we saw the clinic doing, they were always trying to figure out a way to make the scheduling more efficient. From the standpoint of the parents, you just have to have your own expectation. This is a half a day or whatever it is, and just live with it. For the patient, particularly in pediatric, half a day is a really long period of time, right? For kids who can't sit still and things like that. So to me, that's the hardest. That's a hard thing to do. How do we try to set an expectation for our child about, this is a morning and there are going to be a whole lot of different things, and hang in there. We would let him bring his Game Boy so that in between when someone came in, he could fiddle around with that, or try to find ways to make it okay for him to pass the time. But there are, I think, 3 different audiences to that question, and each one has an important part.
And we tried pairing up team members, because we have a really big team now, to try and see if they're similar. So they're asking maybe not exactly the same questions, but overlapping enough so you'd get 2 people in a room at a time. Sometimes that works, sometimes it doesn't. And then you throw in having a medical student or a resident and a learner, and then that I try and get in when I can, but then if you have a learner, they're going in and coming out, and then we're going in together. So it is challenging. I think it's setting up the expectation, and also maybe at the beginning, finding out from the family. Actually, we do a pre-clinic call. So we know ahead of time, we have an ENT appointment at 10:30, or we're doing an oral glucose tolerance. So we're going to lab, we're coming to you, we have to be back in lab. We don't like it. I had this happen recently where somebody was all upset and agitated. They missed an appointment, but we didn't know about it. So anticipating at the beginning if there's a time constraint, and knowing, so that we say, okay, you've already had your annual review and your weight's good. Maybe you don't need to see the dietitian this time, or your meds are fine. You don't need refills. The pharmacist can wait. So I think setting those expectations as well. But it does help from the beginning to know if there is a time constraint that we're trying to meet that. Because otherwise we can consume a whole morning or afternoon. Yeah.
And I'm just looking at the time here. So I believe that we are actually out of time for our session today. I want to thank the audience just for so many great questions. We're responding to some of them in Slido as we go. So please do look there if your question wasn't addressed, or you can feel free to email me. I'm happy to provide some responses or share with our group here. Thank you so much to you guys as presenters. It has been my joy to work with you all over these many months and preparing this session. And thank you so much for sharing your stories and your perspectives on relationships. We know how important these relationships are just to the wellness of all of us and our patients. So, at the end of the day, what are we without one another? We truly need one another, and not a single one of us, patients nor care teams, is an island. I hope this session has given you guys some tangible ideas to take back to your teams and into your patient care. And we wish you all the best for the rest of the conference. Thank you so much.